Thank you so much. We really appreciate the opportunity to hear from you and get your insights on this topic. In the data that you examined, did you come across, and in your own experience, data which stratified children with different sort of craniofacial abnormalities, for example?
That's a good question. Those were not specifically extracted in these studies. We do know that there is obviously an increased risk, and perhaps a more definitive procedure might be very tempting in those patients, especially given the fact that they do unfortunately often undergo multiple rounds of anesthesia, in which case the preference might be to place a stent in those patients. From personal experience, we have performed balloon dacryoplasty in patients with craniosynostosis with great success.
There are a number of questions from the audience asking, do you perform kind of combined procedures? So do the balloon and then also place a stent. Is that useful?
That's a good question. Certainly intuitively it makes sense, although the literature is pretty clear that the outcomes are quite comparable between the two, so it's perhaps a tad redundant. Our pattern at my institution is to perform one or the other. And
then what is sort of the timeline that you might offer the balloon?
Usually we see these patients in referral. Usually it is our pediatric ophthalmology service that performs the overwhelming majority. So by the time they get referred, the patient's usually been symptomatic for a few months anyway, and at that point we initiate a balloon at the family's convenience in the absence of infectious signs.
Wonderful. Are there other comments from the panelists about your own experience with these different techniques?
I'm curious if anyone on the panel ever uses it as a primary treatment. I find that I do a lot of my probings in the office, so under a year of age, but once they get to be over a year of age, maybe they're a little bit more complicated, and if I end up taking them to the operating room, I sometimes just go ahead and do a electrocath. What do you think about that?
We actually listed that as a point for further study. There really has not been tremendous investigation into this concept, but within our OTA, we did mention that that's an excellent area for future consideration.
There's concern from the audience that balloon might be more costly than stent, and I wonder if you could comment on it, whether this influences what you do.
That's a little bit of a controversy in the literature. The study that I mentioned by Cassidy did extrapolate on costs and found that the cost savings was actually fairly substantial for balloon, but the problem with that study is, in that study, patients routinely went back to the operating room to have stents removed, so the waters are a little bit muddy there. That probably doesn't follow more of a real-world protocol in which most stents can be removed in the office. But to my knowledge, that is the only study that's looked at cost and did find a savings for balloon dacryoplasty.
And then finally, is there any age limitation? So the audience asks, is there an age limitation for utilizing the balloon dacryoplasty?
Not at all. In fact, in the occasional patient who fails a DCR, endoscopically we'll make a little nick at the ostium and then pass a balloon through there so as to widen the ostium. And we found tremendous success in the adult population.
Excellent. Well, thank you. Thank you so much. Thank you to our panelists, and thank you for your important questions.
Thank you.
We'll see you at 10:45.
Hi, Amy. How are you?